So what I'm going to talk about today is what is exactly different when we deal with children with CKD and their nutrition. Before I dive into the topic, I would like to make a statement that childhood is a special time uh, that is filled with vulnerability, and this photograph says it all. But it's also a special time wherein you see adaptability and resilience at its maximum. So I must tell you that compared to adults, children can be molded easier, in an easier way. And most often, they would remind us as to what the right thing is to be done for them. So what I would like to do today is to touch upon concepts of nutrition, assessment tools, and management principles. Just like what was being discussed in the last few minutes, here is a long list of medications that a 11-year-old kid has to abide to. And yes, where are the nutrients? Are they hidden between these lines? And you all would agree that children are growing. They definitely need nutrition as a separate prescription. I would like to share some of the pictures of our patients just to give you an idea how we deal with this problem and how this problem is so common, but as you all mentioned, takes a backstage sometimes. This girl is on peritoneal dialysis for ESKD for more than 7 years. She has got hyperoxaluria and is awaiting a kidney liver transplantation they can't afford. And the parents are just happy, fully knowing the reality that she is surviving and amidst them as long as she can. And she's 7 years old with a 12 kg weight, which is equal to a 3-year-old. 14-year-old who went from doctor to doctor for several years and landed in this condition, debilitated, emaciated, not able to even sit up, and succumbed with us, weighing only 15 kgs, and the underlying kidney disease was a posturethral valve. This kid was put on chronic PD, and because of malnutrition, you can see that there's no subcutaneous fat and there's extrusion of the PD catheter. And this is on the other side where the child has Bardet-Biedl syndrome and is obese. And all this come under the heading malnutrition because the WHO defines malnutrition as a combination of undernutrition and overnutrition. So does nutrition status in a child with CKD really matter? And we have evidence to say that yes, it matters because short stature and poor appetite are associated with low health-related quality of life scores. And this was not only studied in the West, but also studied in our center and published in 2019. Malnutrition is an independent predictor of mortality in CKD. The height scores, the weight, Z-scores, the BMI are all associated with increased risk of mortality, and serum albumin levels, when they are low, are associated with increased hospital admissions. Now, how common is malnutrition? A very difficult question to answer because various studies have looked at malnutrition in various ways. Some of them have defined it as growth failure, looking at the height. Some of them have said undernutrition, looking at weight for age or weight for length or height. And wasting has been a terminology that has emerged in the last few years. And I'm sure the adult nephrologists are more familiar with this term, protein energy wasting. It's not still a very well-established term in children. In children, what is common as a terminology when we talk about nutritional status is protein energy malnutrition. And this is definitely very different from protein energy wasting. And I'd like to just summarize that in this slide. In PEM, malnutrition, there is reduced fat in contrast to preserved fat in protein energy wasting. There is muscle preserved in PEM and muscle loss in PEW. There is a decreased metabolic rate in malnutrition, whereas there is increased metabolic rate in PW, and that's what you see even with ESKD or CKD. There is increased appetite in malnutrition, whether it's marasmus or kwashiorkor. The marasmus baby is hungry all the time, and that's typical sign of malnutrition. Whereas in PW, we would have altered appetite. And there's always a good response to supplementation. As pediatricians, we always see our kids who are malnourished do well with nutritional supplementation in terms of food or other supplements. That's not always the case when it comes to CKD and protein energy wasting. So this protein energy wasting, as you all, I'm sure, are well aware of, it has emerged as a problem secondary to the uremic milieu, which consists of a decreased protein and calorie intake, acidosis, uremia, dialysis, inflammation, all this accompanied by increased leptin, decreased ghrelin, anorexia, and insulin resistance, protein degradation, inflammation, oxidative stress, metabolic acidosis, all this we have heard in the previous talk. And this will lead to decreased muscle protein synthesis, increased protein breakdown, and finally, uremia or sarcopenia, which is muscle loss to an extreme extent. In 2008, the ISRNM, the International Society for Renal Nutrition and Metabolism, brought out the criteria for protein energy wasting in adults. And somewhere in 2014, this paper came out wherein the pediatric PEW criteria was adapted from the adult criteria. And this is what the criteria consists of. That is the serum biochemistry criteria, the reduced body mass in terms of BMI, reduced muscle mass in terms of measuring the mid-arm circumference, and the dietary intake in terms of appetite. In the adult criteria, there is emphasis given on the calorie and protein in the diet intake through dietary recall. But in pediatric criteria, it is limited to assessment of the appetite. And then the fifth criteria, which is most important, which of course will not be relevant to an adult, is poor growth. So this criteria is further stratified in terms of severity as mild PW, standard PW, and modified, wherein it just gives us an idea as to what is more severe. That is, modified PW is more severe than the mild PW. So just to give you a glimpse of how the comorbidities of children with CKD are different from the West. So I will take an example of the largest CKD cohort, that is CKID study, which has 528 children studied. And the comorbidities figures are here in front of you. And our study, which was published in 2017, had 78 children with CKD stage 2 to 4. This did not include those in ESRD or on dialysis. And you see vitamin D deficiency, left ventricular hypertrophy, short stature, dyslipidemia. All figures are 2 or 3 times or 4 times more than the West, except for obesity, wherein we had lower numbers of children being obese or overweight. What about PW? Yes, the same CKID cohort, they had studied the burden of PW in these children, and the burden of mild to severe PW was 7 to 20%, and our study that included 123 patients, which was published last year in the Journal of Renal Nutrition, shows that the 70 to 64% of kids had PW. And of course, this is a stratification which gives us a range of mild to more severe PW and the figures. So definitely PW is there. It is existing in children too. And why are we worried about PW? Because evidence has shown that it is associated with mortality, more hospitalizations, cardiovascular complications, and quality of life. Of course, all this evidence comes from adult studies. Coming to assessment tools, you all are aware that the KDOKI has come out with the guideline for nutrition assessment in 2020. And similarly, we have also had PRNT, that is the Pediatric Renal Nutrition Task Force, coming out with clinical practice guidelines again in 2021. Until then, we were using the KDOKI of 2009 recommendations. Just to sum up, what do we look for when we assess for the child for nutritional status? We look at dietary intake, we look at height for age, height velocity, because that's the way we look at whether the child is growing in terms of linear stature. And then estimated dry weight. We would always like to have a euvolemic weight, though it's difficult to assess without in terms of just anthropometry, and we'll have to go in for more sophisticated tools. BMI for height age, head circumference, and NPCR in adolescents on hemodialysis. We have challenges in nutritional assessment, and I'm sure adults face the same problem. There are changes in body composition, of course. This is again very relevant to childhood because child is growing, and at every age group, you would have a change in body composition. Edema comes in the way. It's a major confounding factor for nutritional assessment. The etiology of CKD, like children who have tubular disorders, are short, they're not growing well because it's got a very slow progression compared to a glomerular disease that has a faster progression, and you may not have very predominant growth failure in a glomerular disease compared to a tubular disease. And in pediatric CKD or ESKD, it is the non-glomerular disease that it commonly is the common native kidney disease that ends up with ESKD. So that's a major problem for us. Medications like steroids can affect growth, and comorbidities, of course, which is similar to adults. And of course, there is no single tool that is ideal to assess the nutritional status till date. I would draw your attention to the body composition that I would like to project here. This is the total body, the body weight, which comprises of fat and fat-free mass. And this fat-free mass is further got the cellular tissue mass and the bone and the total body water. Now, the total body water can be extracellular, intracellular water, or the fat-free mass can be just the extracellular mass or the body cell mass. And I would come back to this body cell mass a little later, but at this point in time, I would like to highlight saying that whatever anthropometry we use mid-arm circumference, for example, in PEW, we use body mass index, even in children, or sometimes we go ahead with skin fold thickness. Now, all these are just surrogate markers for fat and fat-free mass. We are nowhere able to capture anything within, beyond fat-free mass or fat. So the limitations of anthropometry and biochemical assessment tools are that the dietary intake can underestimate nutritional status. Serum albumin also can underestimate nutritional status. Height, weight, mid-arm circumference, skin fold thickness, they can all overestimate due to the presence of edema. This is a study that was again conducted in our center and published last year. The body fat, now we know that our children, we studied this in 33 children with CKD 2 to 5D, and we observed that 60% of them had mid circumference, which was low. That means they were malnourished. But is this because they have low fat, body fat, or is the body fat preserved in children? That is what we wanted to study. And we looked at the body fat through DEXA and BIA. We know that the DEXA, though there are limitations, is still the preferable standard method of assessment of body fat in CKD. And we were surprised. 12 to 18% only had low body fat mass. So our kids, though are malnourished, in them, the body fat is well preserved. And there was no difference in the proportion of these children who had low body fat between the CKD 2 to 5 and those on dialysis. Is protein energy wasting common in our kids in CKD? Again, this paper was, this study was undertaken in our center and published last year in the Journal of Renal Nutrition. So we studied 123 children with CKD 2 to 4 and ESKD, and 58% had PW. We diagnosed that with the criteria I had just mentioned. And what were the factors that were associated with PW? It was not the age, gender, or etiology, but only the duration of CKD and severity of CKD, which was not very new to us. Now, looking at children with CKD 2 to 4, 47% had PW, and the right side shows the kids who did not have PW. And we looked at all the PW criteria, and I'm just going to show you what were associated with PW. That was reduced appetite, low mid-arm circumference, and low BMI. The proportion of these children who had these factors were definitely more in children with PW than in those who did not have PW, and they were all significant. What happened to the biochemical criteria like hypoalbuminemia, hypocholesterolemia, low transferrin, and high CRP? Now, this was not significant in children with PW versus those without PW. What happened to children on dialysis? We had 73% with PW, and again reduced appetite, low mid-arm circumference, and low BMI. All were the proportions were more in PW versus those without PW. And again, the biochemical criteria was not significant in terms of the proportion of children who are affected in PW versus no PW. So it stands to confirm that anthropometry is much more useful to diagnose protein energy wasting compared to the biochemical parameters. There is another tool which again is used in adults as SGA, and in children it's called Subjective Global Nutrition Assessment, the SGNA. And we have a 7-point scale that is undertaken to assess nutrition. And this can be done not only by a clinician, but also a trained health worker. And our nurses are trained to do this. And we looked at the validation of SGNA with mid-arm circumference in 100 children with CKD and ESRD. And we found that the SGNA was useful in terms of a good sensitivity and specificity to detect malnutrition in CKD stage 2 to 4, that is pre-dialysis, and it did not fare so well in children in ESRD. The other CKD studies on pediatric nutrition come from the West. That is, they found that children were actually taking good calorie and protein intake along with sodium and phosphorus. The GFR, when it was less than 30, was associated with greater risk of poor appetite. And adolescents, there was lower GFR and obesity that was associated with greater screen time, which is slowly, I'm sure, going to become a problem in our country too. And low hand grip strength and frailty have been studied in few children, though there are many, many studies in adults. So coming back to the body composition, I had mentioned that the anthropometry was just being a surrogate parameters for fat-free mass and fat. And as discussed earlier, the bioimpedance is a good tool to assess the total body water. And DEXA is a good tool for fat-free mass, fat, and bone mineral density. I would draw your attention to this body cell mass because I'm studying this in detail as a part of my PhD. And this body cell mass reflects the metabolically active tissue in our body. So it is proposed that if you can measure the metabolically active tissue, the energized tissue in our body, that would reflect the nutrition status better than any of the other tools. How do you do this? I'll come to that in a bit. But before that, the bioimpedance analysis always has a problem of balancing the hydration status and the nutrition status. So when one has to comment on whether the child is malnourished through a BIA, then you know that the confounding factor is the hydration. They are usually overhydrated, and therefore the assessment of nutrition again is not going to be very clear. So the bioimpedance vector analysis is another important tool that can be used to monitor patients on hemodialysis to target the dry weight. So this is what we use in our center for children on hemodialysis, wherein we created the tolerance ellipse, the vector, based on healthy normal controls in children, and then plotted the resistance versus reactance on this graph. And you see all the red dots are the pre-dialysis points when the reactance and resistance is measured by BIA, and the green dots are post-dialysis. So we would like the dots to go within the ellipse. That is normal. So you see a lot of dots are outside the outer circle, which means it's overhydration. And then with a series of dialysis sessions, you target the dot to go within the ellipse. And that is one good way of targeting dry weight. Similarly, the bioimpedance vector analysis has been implemented in children on peritoneal dialysis. And here you see the 4 quadrants, wherein you have low body mass on the right hand, lower quadrant, overhydration on one side, and you see many dots that are sitting in the overhydration compartment, and few dots also in the low body mass quadrant. And we are trying to study whether the overhydration is going hand in hand with the ABPM measures that we are doing in these children, and is the low body cell mass also going hand in hand with the anthropometric measures. So these studies are ongoing. The NPCR is limited only to adolescents who are on hemodialysis. And this is the interesting part. Did you all know that we all emit gamma rays normally? Yes, we do. And how does that happen? It happens from the naturally occurring radioactive K40. K40 is potassium, which is there within our cells. It is an intracellular element. So it's within all our cells, and this emits gamma rays. And if we had a way of looking at the body cell mass, which means that the active, metabolically active part of the cellular tissue, then it's good enough to measure the intracellular potassium, because 98% of intracellular potassium is there within the cells. So the tool that measures this potassium that emits gamma rays is captured by this tool called whole body potassium counter. And this is the work that is going on in my center. And I'm studying this whole body potassium in our kids with CKD and ESKD, and trying to see if that reflects the body cell mass, which is actually the most important component that reflects nutrition status. And I hope to bring out results of this in the next few years to come. So the management principles, I would conclude with this. We have various guidelines that have just come out in the recent years on the energy protein requirement in children and the calcium phosphate prescriptions in children with CKD. The nutrition therapy, we have something called the suggested dietary intake that has come up in the latest guidelines, wherein you have a range for energy and protein, which is very different from the dietary reference intake, DRI, that was recommended by the KDOQI, where we had just one value. So we have a range here, and that makes it more easy for us to prescribe nutrients to our kids. I know that there are majority are adult nephrologists in the audience, and therefore I will not be going into this detail. But yes, infant feeding is a very big challenge for all of us, and we have something like something called the gastrostomy tube, the G tube, that we have to insert in our kids if they don't thrive well. And all that was discussed in terms of fiber, lipids, bicarbonate, all these are relevant even in children. And an example of how we deal with these problems when it comes to enteral feeds is to use something that is easily available. F75 and F100 are the supplements that are available by the WHO in every setup, in every government setup or every private setup. And this can be used as a nutritional supplement. So we don't have to spend money and get commercially available supplements for children. And in case there is a need for TPN, then an example would be Cabiven, which we have used very rarely in our kids, and that contains amino acids, electrolytes, dextrose, and lipid. And this is again the other supplements that are available commercially, and we would prefer Reno Pro HP because there's no phosphate and we have very low potassium as a supplement for those who can afford and for those who do not do well despite home-based nutritional therapies. And there is some evidence to say that enteral feeds does have an impact on improving the BMI. And intradialytic parenteral nutrition is very important in children. The indications are very few, and it's used only when there is persistent loss of weight or persistent hypoalbuminemia. So the other approaches would be to look at if dialysis would improve nutrition, and there's still not well-established data on dialysis, the increased frequency of dialysis having a major benefit on nutritional markers. Comorbidities, of course, have to be dealt with: hyperparathyroidism, hyperphosphatemia, metabolic acidosis, and vitamin deficiency, as Dr. Anita had just mentioned to us. And growth hormone would be recommended in children CKD stage 3 to 5 and 5D if they have persistent growth failure, and if other factors have been treated in terms of those that affect growth in terms of nutrition and other factors that have already been addressed, and then you still have growth failure, that's when growth hormone is used. Of course, it's expensive, so most of our families hesitate to use it. Then exercise, there are a lot of studies in adults, not so many in children, but the few studies there do mention that the increased muscle oxidative capacity increases, and therefore aerobic and resistant exercises would be good for to increase the physical activity and frailty. Anti-inflammatory agents, there are many, but none of them have been really used in children. Appetite stimulants, again, megestrol has been used in adults, but we have not really used them in children. Anabolic steroids, again, there is some evidence to say that it helps in adults, but again, we don't have consistent studies in children to recommend or implement these recommendations. So to conclude, nutrition, children need it the most. There's no doubt about that. And we need to explore different approaches. And if you just go through the editorials of the Journal of Renal Nutrition in the last few years, you see different approaches like precision nutrition, telenutrition, nutrition that emphasizes the culinary medicine, cooking techniques, various recipes. And we are slowly trying to incorporate these in our CKD and ESRD clinic with our dietitians, wherein we would like to individualize recipes, make children express themselves in terms of telling us what they like, what they don't like, and then we would like to work around their likes and then implement or prescribe the recipes that they would like. So otherwise, the diet chart, I have seen children hate to go to the dietitian because they feel that the diet chart is a punishment. So we're trying to we work on around this and try to make the dietary prescription or nutritional care more child friendly in our clinic. And I would like to conclude saying that, yes, I touched upon concepts wherein we brought the protein energy wasting as a new term in pediatric CKD, and our observations in the studies, assessment tools that anthropometry still is more useful than biochemical parameters, and of course management is always nutrition first, and only after we have done justice to nutrition therapy comes the other adjuvant therapies. Thank you very much again for giving me this opportunity.